Well, it's great to be here with you all, and just thank you guys so much again for having us be a part of it. We're just going to go through a quick overview, and then we're going to open up for questions. Trisomy X is a condition, as you know, with many names, so also referred to as 47XXX, triple X syndrome, which if you type that into Google Images, you will get some crazy stuff. So disclaimer for anyone that's
See the
done
social media talk later today for
Yes. So this is actually a relatively common genetic condition, and occurs in about 1 in 1,000 live female births. But traditionally, it's estimated that only about 10% are clinically ascertained, meaning that 90% of the women with this chromosome variation are walking around and may not be aware of it. That number, I think, is really changing and shifting as we're getting increasing uptake of genetic testing across the lifespan, as well as increasing use of prenatal testing. But that's kind of our traditional number. And there's really two ways that females are ascertained, which just means being identified and getting the diagnosis. So the first would be in the prenatal setting, which many of the families that we got to meet during the session earlier for Trisomy X were identified in utero, and often it's, as many of you may be aware, an incidental finding. So women could have a genetic workup in the prenatal setting recommended because of older maternal age, which predisposes in general to an increased risk of chromosome abnormalities, or because of abnormal ultrasound findings or other problems during the pregnancy, as opposed to those that are obtained, what we'd say postnatally or after birth, which is usually on the basis of medical or health or developmental problems identified across the lifespan. One of the most challenging things that really comes up, especially in counseling, is that this is an incredibly variable condition, and that both the physical and psychological features can vary from female to female. And so a lot of what we hypothesize is driving those medical features and the neurodevelopmental features is really related to the overexpression of genes that escape X inactivation. So in all females, we actually carry 2 X chromosomes, and typically to compensate for the dosage between males and females, males, right, only have 1 X chromosome and 1 Y chromosome, is that typically all females actually inactivate one of their X chromosomes. And so if you have a female with trisomy X, right, they have 3 X chromosomes, and they would typically inactivate 2 of those. But we know what happens in all females, regardless of whether or not they have an extra X chromosome, is there are certain regions on the X chromosome that actually do not turn off, but remain active. And so those are the regions that we think may be really contributing to some of these medical and neurodevelopmental features. These are just a couple of very cute young girls and then an adolescent woman with trisomy X, which really highlight, again, that this is for pediatricians, for geneticists, this is not a condition that has a lot of recognizable physical features that make it an easily recognizable pattern to diagnose based on physical examination, in contrast to another trisomy that's very common that people recognize, trisomy 21 or Down syndrome. So that again contributes to part of the difficulty we have in really getting females recognized by community health practitioners. Sure.
That woman on the bottom is Hillary, and she's now a firefighter.
Yeah.
Very cool.
Right.
Thank you.
That's
That's
right.
great. So this is a karyotype. So this is the standard way that we confirm the diagnosis, whether it's done prenatally or postnatally. And karyotype is just a fancy word for chromosome pictures. So this basically this is all of your chromosomes, right? Your 20 to 25,000 genes in your body are packaged onto these physical structures called chromosomes. And these are present in every cell of your body. So your muscle cells, your brain cells, your hair cells, your blood cells. These are typically taken from a blood specimen. It gets cultured in the lab. They actually extract the DNA. They do some fancy staining techniques, and then they don't actually ever look this nice initially. They actually look like long strands of spaghetti. But what happens is there's a lab technologist who actually then arranges them by size, and then is able to review them for any changes in the number or structure of the chromosomes. So, so they're arranged from biggest to smallest, and so pairs 1 through 22 are what we call your autosomes. Those are the same in males and females, and we get 2 copies, right, of all of our chromosomes. One comes from mom, one comes from dad, and the egg and the sperm that go to make the baby. And then your X and Y chromosomes, again, are what determine gender. So for a female with trisomy X, that's characterized by the presence of the 3 X chromosomes, which you can see at the bottom. Ooh, here's a circle, yes.
That's a genetics question. This hasn't been clear before. From who does the extra X come?
That is a great question, and I think we might be going into that on one of the next slides. And if we don't, please ask it again, and I will come back to it. All right, okay.
There you go.
I must be clairvoyant because there it is. So how does this occur?
We
So-
planted that question.
Yes, you have earned your $5. So the trisomy X really it arises from what we call a chromosomal non-disjunction event. So in the normal process of cell division, you actually make copies of all your chromosomes and you give the exact same number, 46, to each cell. But when you go to make egg or sperm, you're making what we call your gametes. Those cells are only going to have half the genetic material. So instead of 46 chromosomes, they're going to have 23, because that's going to go along with the egg or sperm, which each have 23 sets of chromosomes. And then when they fertilize or form a zygote, then that is what's going to form the normal complement of 46 chromosomes. So what happens is that in the process of making eggs or sperm and dividing up those 2 pairs of chromosomes, so let's say the 2 X chromosomes, what can happen is that normally the chromosomes will kind of line up and pair together, and they know which is their buddy that they need to pair with. They exchange genetic information as a mechanism to create genetic variability. And typically they would normally divide and each go into 1 daughter egg a piece or 1 daughter sperm per se. What happens is that sometimes this non-disjunction event is basically, think of it as the chromosomes getting sticky. And instead of separating like they should, with 1 going to each gamete, 2 go to 1 and 0 go to the other gamete. And so that basically creates a population of eggs or sperm that would contain an additional X chromosome. Okay, when they've done some traditional cytogenetic studies, which just mean fancy genetic lab research studies, looking at where does this typically come from, they found that most of the time it is coming from the mother, that it is a maternal in origin, and that typically these are happening in the first step of the fancy process of creating eggs or sperm called meiosis. Paternal origins have been determined in a small number, and we really don't see a whole lot of difference whether or not it's a maternal versus a paternal origin in terms of phenotype at this time. As opposed to other chromosomal abnormalities that people might be a little bit more, have heard of or be familiar with, like trisomy 21 or Down syndrome trisomy 18, which are more strongly correlated with maternal age. There's a very weak association that's been seen with older maternal age and the risk for sex chromosome variations. A small number of trisomy X occur due to an error in cell division after that fertilized egg, or what we call the zygote, is formed. And that's called a post-zygotic event. All that means is it happened after fertilization. And so what you get is actually a mosaic trisomy X, which means that, and mosaic is just a fancy word for saying that some of the cells are going to carry that extra X chromosome and some of the cells are not. I'm going to have the normal complement. All right, so I think I just answered this question. Can triple X be mosaic? Yes. All right. And it really, in terms of mosaicism and what the effects are on the child, that really varies actually by the distribution of tissues in the body that carry that genetic change. And so it's difficult because sometimes we're just sampling from the blood, but we can't sample necessarily from the skin or the brain or the gonads to see where these changes are being present, where there may be some real questions, for example, looking at the brain for development or looking at the gonads to know about risks for example, premature ovarian failure. So certainly can be mosaic. We think that there's, typically with mosaicism, you tend to see a more mild clinical features, but it's incredibly variable just based on where the genetic change is found. And so in terms of what conditions or medical features we've seen associated with it, and this is really going again into a little bit more of the genes, which we already talked about, that we really think that a lot of this is driven by changes in gene expression. And if any of you have a chance to hear Dr. I'm going to mispronounce his name, Rosamond's talk from the NIH about genes and behavior, they are certainly really starting to do some exciting work into uncovering these new mechanisms that we have hypothesized about for quite a long time. So I think this is the last slide we're going to cover, and then we're going to open up for questions. But this is just a summary of some of the features of Trisomy X. And did you want me to go through these, Rebecca, or were you hoping we would just start talking about
We can go through
these?
them. Sure.
Okay.
If you want to just quickly
Sure. So some of the common clinical features that are recognized, and I'll just put up a picture for this one real quick, are just some changes in body proportion. So girls tend to be on the taller side, so 75th percentile or above for height, with a little bit difference in body proportions where the legs tend to be longer and the torso a little bit shorter. However, we know that there's tremendous variability, so we've certainly seen a wide variety of statures in females with Trisomy X. Other features that we can see commonly are something called hypertelorism, which means widely spaced eyes. So if you look at the girl in the bottom hand corner, you can appreciate just looking at her that her eyes are a little bit more widely spaced. Some children can have what we call epicanthal folds, which are just little folds that cover the inner, what we call canthus of the eyelid, where the upper and lower eyelids come together. Those are common in the general population. What we call fifth finger clinodactyly, or curved pinkies, which may be familial or just run in families. And then flat feet and low tone. And then just going back, certainly other things we see are motor tone issues, typically low muscle tone, and coordination difficulties that tend to be more mild. Renal and cardiac malformations have been reported that typically are sometimes found incidentally. Most of the cardiac issues have been what we call septal defects, which just means there's a little abnormal hole that was left in the heart that, at least in the females we've followed here, have not required surgical intervention. Seizures are found in about 12 to 15% of females. There have been some reports about increasing frequencies of autoimmune disorders, so thyroid disorders, as well as some of the other rheumatologic disorders like lupus and Sjogren's syndrome. Puberty tends to be normal for a lot of females. They tend to get their periods on time and progress through puberty without issues. Typically, we see, at least anecdotally, that a lot of females go on to have healthy pregnancies, but we also do know that there's a secondary group of women that go throughout their life and get diagnosed as part of the workup for infertility or having difficulty, and then are found to have the condition. And it's usually due to what we call premature ovarian failure, where the ovaries are not producing as they normally should be. And then we'll probably touch a lot more on the developmental and psychological features, both hopefully answering your questions, as well as we have a research presentation at about 4 o'clock today, which will go into a lot of that in more detail. So I think this is probably, hopefully, a great time to open up and ask questions and make sure this is really meeting your guys' needs.
In talking to her primary care physician, and I'm lucky, my primary care physician for her was a geneticist first, so she has more knowledge than a lot of pediatricians folks have for their daughters. There's some test that they want her to go for, I forget what it's called, and people are asking me. They want her to go to the endocrinologist and test for her AIDS, and I don't know, to check to see if she's at risk already for the ovarian failure. So can you speak to that, because I don't know the words.
Yeah.
Thanks.
So there are there is a hormonal test that's called an AMH level that you can do. That is it's a sign of ovarian reserve. And so if there is premature ovarian failure or any signs of it, then that level can be monitored along with another hormone that's called your FSH, which is your follicle stimulating hormone, and that one also, if your ovaries are failing, will start to increase a lot. And so, there's a lot of research that needs to be done in terms of what, does every girl with XXX at puberty need to be monitored? Clearly in my work thus far, I've seen many girls go through puberty and, continue on without any, changes in terms of menstrual cycles and regularity and other things. So, we feel like usually as long as you're menstruating on a regular basis with normal periods, most of the time in adolescence and young adulthood, that means that things are, hormonally working the way they should. But we do need to know more about this, right? Because we do know also that, when you take the population of women who have premature ovarian failure, that there are higher, they identify women with XXX in there. The first woman described with XXX was actually 18 and presented with, what's called secondary amenorrhea. She started her period and then she stopped at 18, and so they were doing the workup there. So, we need to learn a lot more. I don't think there's any harm with doing blood tests to monitor, but right now, and if people are really interested in following that, but there's not a standard like you have to start doing this at this age right now to know if it's something we need to start worrying them about, right? I'm not sure every year in adolescence, if it isn't a big deal, that we have to start thinking, oh my gosh, am I gonna have early, yeah.
Like she's 11.
Right, but the other side of it is that if it is a higher risk, there are procedures where you can go in and save eggs, right? And if these are girls who want to go on and then be moms later on, and we didn't do something earlier, and we could have, and now they're 35 and wanting to have a baby, but can't, then, so it's going to be really important. We're going to start to kind of tackle it a little bit more in our clinic population for sure, because it's really important.
Yes.
So are we allowed to ask whatever right
Yes.
now? Yeah. So I have a 7.5-year-old daughter with Trisomy X, and she was diagnosed last year following a couple months, probably about 6 months of stomach aches and headaches all the time. And it wasn't just at school, and it wasn't always during unpreferred activities. And we were not necessarily seeing any reason why she would be anxious, but she just didn't, that wasn't my gut feeling. So we've had her evaluated through one of the clinics and with a psychiatrist and the school and a neurologist. And the neurologist thought, well, maybe it's just abdominal migraines. The psychologists were more along the lines of us, probably anxiety. And, plus a million other different body aches and different things that have happened. And so I just kind of was curious if this is something that's sometimes seen with Trisomy X or not.
Raise your hand if this story sounds familiar.
What do you guys?
Yeah, so we see a lot of anxiety. Girls seem to be at a much higher risk for anxiety. with trisomy X, and we see a lot of somatic symptoms. Not to say that we know that your daughter's symptoms are purely somatic, but we know that anxiety is really associated with stomach aches and migraines and headaches and stress. And so that is really, as you just saw, very common presentation to our clinic. And we'll be looking more at girls that are prenatally ascertained, so that we know whether we're just seeing the kids that are anxious, or are we seeing, or do we really see it as an yes? Are you going to add to that? Yes, it's girls. Does that answer your question?
Yeah, I guess part of me was just like, I did this like log for months tracking the physical symptoms, and because I'm a behavior analyst, so like we're gonna take data. But when I didn't notice any pattern, and my gut still was like, I don't know how much of this, I mean, I felt like anxiety maybe is a factor, but she's just never been that, I don't know. I noticed it when she's tired or overstimulated because there's a lot of big kids around.
Right, so anxiety is oftentimes stimulated by a sensory environment, and oftentimes we all are more on edge when we're tired, and fatigue is not an unusual symptom to see either. So those things tend to go together, and one of the things we're finding is that a lot of our girls with trisomy X have more externalizing symptoms of anxiety than necessarily saying, I'm scared, I'm nervous, I'm worried. Not that they sometimes say that too, but we see a lot more of kind of a behavioral presentation of anxiety.
And as far as treatment goes, I'm wondering, like some of the advice is just ignore it, and just don't feed into
Well,
it.
that's helpful.
Give her more. But, don't feed into
that work?
Not reinforce the behavior, but and it cut down some, but it's still definitely, present.
I think, this is a very common, cluster of symptoms that comes up. And it's really challenging, right? Because, okay, maybe it's anxiety, maybe it's not, but it really feels like she's having pain, but, and there are some times where it does inhibit what she's doing, and it comes up all the time. And, even if we don't reinforce it, I hear about it sometimes, but, I don't know if it's to get attention or to avoid things, the whole story over and over. I think, there's a couple things that are really important. The first one is that, definitely doing the evaluation to make sure there's not a medical cause, and a medical etiology is really important, right? Because there are definitely cases where it could be abdominal migraines, and it could be, there's another condition called EOE, and eosinophilic esophagitis, that causes a lot of abdominal symptoms and problems from the GI perspective. And so those are important things to think about and to see, I think chronic abdominal pain, you need to see a gastroenterologist to really see what happens. Despite that, a lot of times you still come up with, maybe she has constipation, or maybe she's a little bit allergic to milk, or, there's these other things that, are still really nonspecific. And so, if we're thinking about the psychologic kind of contribution to pain and whether or not that's, underlying some of the complaints, and you're seeing those symptoms of anxiety or, other emotional difficulties, I feel it's really important to treat those, right? So let's get and make sure we're doing the behavioral treatments that we need to, and working with the psychologist who's going to understand how to approach it the right way. That's a whole other challenge and discussion. And then also, considering whether or not, if it is a situation where it comes up a lot, treatment with medication might be helpful. It doesn't mean they have to be on medications for years, but if treatment leads to, a trial of treatment leads to 80% improvement, 50% improvement, then you feel more comfortable saying, this is good. If you treat for a little while and, you feel like, I've done 2 or 3 months of treatment, nothing is better, and I don't see any improvements with it, well then, that wouldn't be the way to go. But sometimes it is that kind of, we got to try a lot of different things before we figure out, how to help it.
Thank you.
Yeah. Just to bounce off of her question, my daughter, complains of stomach aches all the time, and just the day before we came, her doctor recommended that she have an X-ray for abdomen. and they said she was constipated. So, but I mean, she has never had a regular bowel movement schedule, and she will go 2 to 3 days sometimes between going to the bathroom. And so I brought this up to.
Anyone else?
So I brought it up to my pediatrician with one of your articles in hand, saying that there could be issues with kids with trisomy AXYS. No, there's no reason, you know, because I said, she will do some tests. Well, there's no reason for tests, why do the test? So, is she just constipated? Like, how do you know?
Well, you treat it, right? You be aggressive about treating the constipation. You get an x-ray that shows that she doesn't have any more constipation and the symptoms are better. Or, you know, hey, we've treated this constipation and this is still an issue and it comes up all the time. So what can we do next in terms of further evaluation?
You know, I should have said in the very beginning, we see many conditions associated with trisomy X that we just treat them the way we would treat that condition.
Yeah.
Yeah, there's no special, you know, it would be the approach to constipation in a typical patient. But you know, if it's not getting better with that treatment, then that's, you know, then, hey, this isn't working.
Yeah.
Can I build off on that a little bit and go in a little different route? My daughter has dealt with a lot of that, and she also has been diagnosed with ADHD. She's 14 right now. She was diagnosed with ADHD as a elementary school student, 3rd grade. We tried the ADHD medication, and it helped to help her focus and get on track a little better. But by 5th grade, I took her off because emotionally it just seemed to be wreaking havoc at home with her, but not in school. So we tried a little other medication to help her with the anxiety. It was just beginning to show then. By 6th grade, we tried stimulants again for the ADHD along with anxiety, depression medication. And what I found was the ADHD medication was making her so anxious. And we tried about 5 or 6 different medications. And the reason I bring it up after your question is when she was on the stimulant, we lost most of these medical complaints from her. So the stimulant helped with that. But emotionally, she became super depressed, super anxious. We now have no anxiety, no ADHD medication at all for her. She still suffers a bit from the anxiety and depression, but nothing like where she was. And I don't know, is this an ADHD issue that I can to work with, or is it related to trisomy X, and is there anything we can do for the ADHD and executive functioning besides the behavioral stuff?
You mean from a medication perspective? So there's 2 talks tomorrow that are going to be focused on medications. So definitely come to those for a lot more details. You know, it's challenging what you describe, right? We have some symptoms get better, and then some symptoms are worsened. And so what is our balance and what do we do with that, right? There's definitely different classes of ADHD meds. And so, you know, it would take some discussing of like, what have you been on and not? And then thinking about stimulants versus non-stimulants. There's also some kind of non-traditional medications that treat ADHD, but aren't necessarily, you know, FDA approved for the treatment of ADHD. So some of the antidepressants actually can help with some of the ADHD symptoms as well, like Wellbutrin. So, you know, there's a lot of different considerations in terms of the medication treatments. I will give a talk on, because I think it's always a big and important decision when families are deciding to use medications. You know, how do I decide if they need it? What is the, you know, when should I start it? I'm worried about this and this and this and this. And that balance between we're doing, you know, anytime parents are giving a child a medication for any behavioral or emotional kind of concern, you should feel very comfortable it's helping that child, right? Because if you're not sure or you think it's causing a lot of problems that are, you know, those risks and negatives outweigh the positives, then that's just not going to feel comfortable to anyone. It shouldn't feel comfortable to you. It shouldn't feel comfortable to someone prescribing. So, but, you know, so yeah, there's a lot I think you can do. I do want Rebecca to touch on the importance, though, of the behavioral interventions and supports, because, you know, medications are a piece of any treatment for emotional or behavioral difficulties. And, you know, while that piece might be a little bit bigger in some kids than others, it's definitely not the whole pie. And the whole pie of all those other treatments is really what's also really important to support that.
One of the things I love about working in the clinic I work in is that I work really closely with Dr. Tartaglia to do what you are talking about right now. So we will do a really thorough evaluation to consider what are the primary symptoms and what are the primary symptoms that we need to treat, and then what are the ways we would treat them. So generally speaking, and I don't, can't answer to every single kid, but in general, first of all, we want to rule out any language-based learning disabilities or language disorders in general. We want to do that for two reasons. We want to do it for academic reasons, but we also want to do it because one of the main reasons we mediate our anxiety and our mood symptoms is through language. So when girls are at a disadvantage in terms of their language, they don't have that advantage to talk with you about what they're feeling, what they need, how they need the things they need. And so that's one of the things that's important to consider. Because, and the reason I bring this up when you bring up ADHD is a very prominent symptom. It's very easy for people to diagnose ADHD. There are a lot of psychologists out there in my world who are very, very comfortable with diagnosing ADHD. For less verbal children, they may not pick up on the anxiety, they may not pick up on depression, they may not pick up on kind of underlying mood issues. So oftentimes the attention will present, and then there's other issues that when kids are in clinic with us, we will be able to pick up. Or learning difficulties, and that's the other thing that can really impact the way girls function in their world at school, and it can be missed again. So, in terms of treatment, I want to make sure we've dealt with any speech issues. I want to make sure that we've dealt with any sensory and motor issues through an OT, because that can also be very impairing for girls. And then I want to look carefully at their attention and executive functioning. Oftentimes our girls present more with inattention than true hyperactivity. And then I look very carefully at the mood disorders, anxiety and depression. And the treatments we would recommend are the same treatments we would recommend for any of those conditions if it wasn't in trisomy X. So for attention deficit disorder, we want nice behavioral interventions with consideration of whether or not medication would be helpful, appropriate supports and accommodations in school so that we're certain that any learning disability is being accommodated, but also attention is being supported. And then for anxiety and mood disorders, we would generally recommend a cognitive behavioral therapy approach. Depends on the age of the girl and the situation and all of that. But the trick here is to find someone to work with her that is a little less verbal, more willing to be maybe visually based, drawing, art, those kinds of things. And then some of the alternative ways that help a lot of our girls is doing things that they enjoy with people that are sensitive to what they do best and can help them do it. Did I cover most everything, you guys? Anything I missed?
I have a question. Do you find there's certain diets, like foods, that trigger certain symptoms or that help with some of this?
You don't want that?
There are definitely higher rates of food allergies in trisomy X. So, it's not something to minimize, because when there are food allergies, there definitely can be symptoms that go along with that. Most of the time, those symptoms are GI or, true allergy types of symptoms. Do food allergies contribute to behavioral difficulties? If there's any, I would say usually probably not, if that's the only thing you're seeing, right? Oh, she's having these behavior difficulties. I wouldn't say the first thing you need to do is look for food allergies. If you have any other symptoms related to food allergies, then you can look for that. So no, there are not any actual specific diets or anything else that we feel are recommended for behavioral challenges. You'll hear a lot about, oh, you can't have added dyes, you can't have, gluten, you can't have this or that. In the past, I would have said, there definitely are some kids, these diets don't get perpetuated if they don't work for somebody, right? And so, there's probably a very handful of kids where it makes a big difference. We don't know who those kids are. A lot of the diets are really hard to follow. And so, if you really feel like, okay, we want to try something, then it's really important to find out what are we going to do, and then, make sure you can enforce it so you can really know whether or not it's helping. There aren't any specific that I recommend, except, a lot of times when you cut out gluten or you cut out food dyes, you're really just cutting out a lot of crappy food, right? And so if you're giving them good food, I'm not sure it's the gluten or it's the food dyes, but you're giving them a pure, better diet that doesn't have as many, ingredients on the box. But then, these days, there's a lot of gluten-free stuff out there now that's gluten-free that's filled with all sorts of other stuff too. And so what used to be gluten-free diet is now the gluten-free diet is a little bit different in that it's got a lot of other additives to make it gluten-free.
Yes.
I just had a question. My daughter has pretty serious cravings for sugar. Do you find that?
Does anyone else see that?
Yeah, it's disgusting.
I can speak to that. I hear this all the time. So cravings for sugar, I used to think was a Facebook myth that was perpetuated by parents because you hear it and then oh yeah, my kids love candy too. And all kids love candy, right? So, I'm like, what? But, I have learned over the years that this is extreme in some situations. We are drinking maple syrup, we're climbing on top of the cabinets to get to the raw sugar and doing gross things that, are almost like too super sweet that most kids even would not do, right? She's always hiding candy bars, she's always stealing gummy bears, she's finding wrappers under the bed and in the couch, and, things that it wouldn't necessarily be unusual in a typical kid, but the degree of it is pretty much. So do we know why it happens? No. I keep telling our endocrinologist, Shan Lee, that she needs to figure out what it is and what drives that, but it definitely is something that's there.
We have a bike lock on the sugar cabinet in our house.
Well, she's an adult. I can
She'll-
buy my own
Yeah,
stuff.
you do. We have a bike lock for our dog.
I controlled it until she got a job.
Yeah.
And then, she goes crazy.
Yeah, I've heard of it. I haven't heard of it being associated with the trisomies. That's what my face was, like, oh, interesting. It was an interesting look. It was not a...
Not skepticism, no.
Not a skepticism look. Yeah, it's important. So, I'd love to learn more about that. If we can figure it out, I think, it's not just the intake of the sugar, but, it's the safety of climbing up and drinking. And but it's all like it's dental and it's, and it's, sometimes getting kids in trouble stealing things at stores and there's a lot of other implications that can come from it. So that's really important to look more into.
And from my perspective, I think the other thing you have to take into consideration is a lot of our girls, no one here specifically, but a lot of our girls are a little bit immature. They have poor impulse control. They're not using the kind of standard parent guidance. Oh, we don't want to do that much sugar. It's just for a treat. They're just not as sensitive to some of that parent guidance and impulse control that maybe another kid would be. But as we've talked about metabolic differences, I am very struck by the metabolic differences we see in our girls. More fatigue, more unusual craving for different kinds of food. There has to be something here that we need to learn more about.
Yes. I have a question about behavior, because my daughter, she's 5.5, and she just finished pre-K 4, and she was in pre-K 3, pre-K 4. She's an angel at school, and when she comes home, not so much. So,
Susan, that's the most common question you get on the phone, Susan.
That's one of them, that's definitely one of them.
Is it? Okay. But her neurologist says, well, if she's behaving that way at school, she's choosing to behave act that way at home. And I don't think so. And I also think she has so much anxiety that she won't even express herself. Right. And it will so then when she comes home,
She feels safe at home, she lets it out.
So it's.
So this is very common. And one of the things that we're concerned about is, can everybody hear me okay? Yeah. One of the things we're concerned about is that very structured settings seem to really fit the bill for our girls. They really do much better when it's structured, predictable, relatively short kinds of pieces of performance that are required, like in school, usually grade school. We see more challenges in middle school and high school, certainly. But, and then when they get home, everything breaks loose. Okay, honestly, those of us that are parents know afternoons are oftentimes tough. Our kids come home tired, our kids come home cranky, they've had enough. But this is really much more of a problem for girls with trisomy X. And I think it's that combination of what I mentioned earlier, that they are asked to be paying attention for a long time. They're asked to be monitoring all this heavy verbal stuff all day long. And anxiety usually is internalized anxiety, where they're not able to say to the teacher, you know, I'm feeling a little overwhelmed, can I take a break? And then learning disabilities are another important consideration, that they may be working really hard in school. So what happens when we get home? Now we're tired and it's been a long, hard day. It is really common to see difficulty after school. I like it when girls can get a nap. Naps seem to last longer in childhood than for other kids. They're really helpful. Anybody else? Naps? Yeah? Yeah, long ones. And oftentimes I find that when I recommend to parents giving their daughter a nap on a regular basis, they're not as long. They kind of do better. It's when they're kind of catching up. So that's a consideration. But I humbly disagree with the neurologist. I do think that life is more challenging for girls with trisomy X, and I think when they get someplace safe, they're going to let their hair down. Which doesn't mean that that's okay. We want to do some things, but the first thing when I'm seeing a girl in clinic is I make sure she's got all the school supports she can, so school's not so hard. I'm very concerned about too much homework coming home. So anybody have problems with homework? Behavior problems with homework? Yeah. That's the other thing, is if we can reduce homework so that they're not coming home facing another 2 hours of school after they just left school. Does that make sense? Yeah.
Okay. So I have a question related to the nap thing. So I have a 15-month-old, and she takes 2 naps a day, just on her own. And my family is like, that's too much sleeping for her. But then she'll also then go to bed about like 8:39.
Enjoy it.
So I'm like, should I not be letting her sleep that much? Or is that something that's actually helping her? Because I'm just doing what I think she wants. Because she does kind of get overstimulated, so when I notice that, I'm like, all right, you need a nap. You know, so I don't know.
Well, I think just in general, as a general pediatrician, we see incredible variability in kids' sleep patterns across the spectrum, but we've also talked a little bit here about, you know, fatigue being something for girls with trisomy X. So I think certainly if you notice that she seems to be overstimulated and seems to really respond well, that you notice a change in her behavior after the nap, I think it's totally reasonable. Kids actually need, at 15 months, they still need a good, you know, sometimes 10 to 12 hours overnight, plus 1 or 2 naps during the day. So there's just so much brain development still going on. So I think even as a general pediatrician, 2 naps for a 15-month-old is still well within the normal limit.
Be grateful for it.
Yeah.
Because I'm like, all right, maybe I should keep her up. Maybe
Yeah.
I should.
No, I would, if she, when you put her down, she conks out and she wakes up and she is a happy camper, I think that is,
For me,
That is a good
as a
thing.
psychologist, sleep is one of the best things we can offer for our children. There's no side effects, or relatively few. Now, getting kids up in the morning can be a harder problem, you know, but it is a relatively easy thing to provide as long as it's not interfering with school or getting up, which we see really, I think, more in the guys, that difficulty getting up in the morning than we see in the girls.
And she's an early riser, so like even with her 2 naps, she's getting up early. So I'm like, by 9, 10, she's ready for a nap because she's already been up since 6. And
We have 10 minutes, and so I want to make sure we get to everybody.
Well,
Yeah.
there's a slide that showed that, I think it's from the latest paper that was published, the list of symptoms.
The medical?
I think so, yeah.
This one?
No, but I think actually, really, either one of them would have to do with my question. These are lists of every possible thing that you've seen with somebody who also happened to be diagnosed with trisomy X. It seems to me, our experience in the last year or so, since that's usually the first list that people find when trying to learn about the disorder or the condition or whatever you want to call it, our genetic counseling the first time with the test results was, this is what your daughter's going to have. Here's the whole list. This is everything. And it seems like most people don't have most of the things on it. In fact, most people don't seem to have any of it, is what we're learning about.
So this is common in clinical genetics. So, you know, your child did not read the book on trisomy X the same way we'd say a child with Down syndrome or a child with Noonan syndrome. These other conditions did not read the book on their condition, and that we were really reporting medical features that families were reporting, and to more kind of increase awareness and look a little bit at, well, are there things we need to, that seem to be at a higher frequency than the general pediatric population that we should be watching out for, because they could have complications. So, for example, we know that if children have untreated thyroid problems, that certainly can influence brain development. So consideration of those, particularly if they seem to be more common than the general population, but by no means is any list a predictor of your child is going to have these things. So it's actually, we can see incredible variability in medical features, and we really don't understand why some kids seem to get the entire list, and that those were maybe some of the families that felt like, I'm raising my hand for everything, while other people may say, you know, my daughter's not having any of these issues, do I need to be worried about them? The whole reason to report it was really to help be a resource for healthcare practitioners in the community to have just an awareness of what else we do see that may not be recognized, but should be something just to think about or consider if you're coming in for a problem like abdominal pain or X or Y, whatever.
But the other part that we're concerned about is making sure that we have a low bar, because we know girls are at risk for things that we don't want to let go and have them develop into more serious concerns. And I think that's one of our experiences from the clinic, is that when we don't get in there and support, oftentimes things can really develop in a way that we hadn't wanted them to.
You know, I think the most important word is risk, right? And I think a lot of times when you read papers, and I mean, I'm always editing, is at increased risk for, is not, you know, girls with trisomy X have tall stature, learning disabilities. They don't all have that. And also, when you look at the rates of some of these things, even though they might be at increased risk for, I mean, especially some of the more significant ones where, you know, there's only 9% who have hip dysplasia. That means the majority of the time they don't, right? And so I think a lot of times we don't report how often it's normal, but we do report how often those difficulties are there.
You know, one of the reasons why I'm so excited about the study that Dr. Tartaglia announced this morning is because there is a lot of bias in the literature. And so this study that we're getting ready to start is looking at a prenatally diagnosed population that has a lot of the bias removed because just because of the nature of the study. And so it's going to help address kind of that concern is, you know, are these publications with the tables, are they biased because of how the child was ascertained initially versus prenatal, you know, naive populations?
We've got 5 more minutes, so I want to hit some.
She has her hand up.
Yes, I was just going to say.
Hi, my name's Karen, my daughter's Brianna, and she's 13, and we had to go through Indian Health, but they weren't very helpful. They have different insurance, we have a doctor at neurodevelopment at Children's that's she's the only one that ever briefed me about anything. And I only get to see her, you know, maybe twice a year and stuff like that. And so I'm trying to find a doctor for my daughter. Since she's 13, should I, you know, is it just hit and miss to find a family practice doctor? Should I keep her with pediatrics? Or, I don't know, I want to find somebody who's hopefully going to believe me with all these things that she goes through and not that she's just okay.
First of all, I just want to ask real quickly, have other people had trouble with this, finding a physician that really understands and can, yeah, so this is a really common issue, and it's the reason why we keep Susan so busy, but, because everybody calls Susan.
How do you answer this when people call you on the phone? Do you get this, I'm sure?
Yeah, I do. So I think where you are right now is a very big step in the right direction, being part of a national organization that has good resources, that has good people across the country to help direct you because, well, you know, we do a great job and we're based out of Colorado. I'm not familiar with all the providers that are in all different cities and states around the country. So I think AXYS is a great resource to rely upon. I do think that families are faced and they have to be persistent with educating providers. And so whether it's our clinic or AXYS that can provide you with materials to bring to your doctors so that you're not just saying things, but actually demonstrating medical, you know, articles in medical journals. I think we often give medical journal articles to families and in some ways I feel like they read it and think, is this really meant for me? But it's a tool to teach your doctor and other doctors about what's going on as well. So you don't have to make the case. Now, that's not to say that they're just going to take it and put it on the table, but you have to be persistent, and that's hard. It's really hard.
You know, resources from other families, like Susan was saying. And then the other thing is sometimes providers, you know, when it depends on the person, but when they get information from a family member, you know, they might not be aware, right? So then they feel like, oh my gosh, I'm intimidated, or I should know about this. The mom knows more than me. You know, there are some who'll be like, oh my gosh, thank you for sharing, and others who won't seem as receptive. One thing you all can do is make sure you say, you know, the doctors at this conference, they were all really nice. They want to, you know, if you have any questions, you can call them. They said you could. Their emails are on the paper. And so, you know, and then that kind of, you know, maybe they're not comfortable asking you questions, but they would reach out to other professionals. And we have a lot of like, you know, I get doctor calls at, okay, the family made me call you. But it helps because then you can have a conversation and really validate a lot of what the patients are usually saying, right?
Last question, we're right at the end. They're telling me to finish.
Me?
Yes.
And I'm 22 and I have Trisomy X. So if there's any parents that want to ask me any questions, feel free to. I didn't find out till I was 18, so that was like 4 years ago. When I was little, I've asked some parents about this, but I had a congenital heart defect. Is that common in most girls?
So we see about 8 to 10% in the clinical cohort, which was about 74 girls that were described, and it was a mix of prenatally identified females and females that were identified after birth. And so those were the percentage that did have a heart a heart defect or a structural change in the heart. Most of those were little persistent openings, either between the two atria of the heart, so the heart has 4 chambers, or the 2 ventricles, and they didn't require surgical intervention, but may have been monitored by a cardiologist. And so that's one of the reasons we have on the recommended screening guidelines that we've suggested for all females with trisomy X to have an echocardiogram at one point, typically after the diagnosis is identified, just to screen for a structural heart defect.
Kristen, where's that list? Where can people find that list?
So I think we have copies of the paper that was in the American Journal of Medical Genetics.
Handouts.
And there is a table in there that has suggested guidelines for evaluation.
Many of these slides came from that.
And if you come at 4 o'clock, there's actually like a literal snapshot of what it looks like as well. So I think we do have copies of the article
That was also planted.
available for anyone to take. So that way you feel free to take those back to your community health providers. Yeah.
Okay. Oh,
Yeah, they gave us permission.
So we're all here, you guys, for the weekend. If you didn't get a chance to answer questions, so please feel free to reach out.
yes, thank you, and thank you for participating. We really appreciate it.